is by Professor Michel from Switzerland. He is a stroke neurologist with medical training in Basel, Cape Town, Boston, and Lausanne. He's head of stroke center at Lausanne University Hospital, and he's a professor of neurology. He has founded the Acute Stroke Registry and Analysis of Lausanne, which is a Astral registry, and he does a lot of research. He is actively involved in the endovascular treatment. And today he will be talking, what Dheeraj has already formed a basis, and then Mank told about it, when to treat, when not to treat. We're talking about deciding thrombolysis for difficult cases, which all of us at every stage we face, difficult cases, where the dilemma is to treat or not to treat. Over to you, Professor Patrick Michel.
Hello, dear friends and colleagues in India. I'm very pleased that I can talk to you about the challenging problem of thrombolysis in difficult situations. So my disclosures are still the same, the National Science Foundation and the Heart Foundation. I also have to disclose that I have already thrombolyzed acute stroke patients outside strict international criteria. And that's exactly the kind of things we have to talk about difficult situations that are sometimes inside and sometimes outside the usual criteria we all know. And this is our checklist. We go through the menu of today. Well, as you can see, it looks like a Swiss menu, but in fact, it is also an Indian menu. It's exactly the same difficulties you have in India that we have in Switzerland. So if we start with the first chapter of unknown and late onset stroke, we have already another talk about this topic today during the summer school. I think Dr. Padma will talk about it. So just a short summary. As you remember, in unknown onset or late stroke, we can replace the time with imaging. That is, we can do perfusion imaging and core imaging that will help us decide which patient we should still treat in the late time window or with unknown onset. And there are about three good definitions for mismatch. As you remember, the core penumbra mismatch that you can measure with perfusion imaging, the core clinical mismatch. So you only measure the core, for example, again with perfusion imaging. And then if there's a little core and a high NHSS, you would have a core clinical mismatch. And then there is the DWI flare mismatch. So a positive DWI and a negative flare, which means that the patient is within the first 4 or 5 hours after stroke. And in my hospital, what we do, of course, we do use this perfusion imaging and MRI-based decision tools, but sometimes you cannot do perfusion image and all you get is a plain CT. And in this situation, we would then, of course, need to do something else than the ones that have been scientifically proven. And what we do is, for example, we try to replace perfusion image, such as the aspect score, that will replace the core image. As you can see, this patient has aspect score of about 8. You cannot see the basal ganglia, so this is the core. But if the patient has a relatively severe NHSS, the core is rather small, so we can assume that this patient could still be treated in a late window thanks to the core and clinical mismatch based on plain CT. So for example, on the left side, you have the official scientifically proven way, and on the right side here, you would have plain CT-based aspects-based mismatch, for example, the NHSS moderately high and an aspects which is quite high. And if the NHSS is even higher, severe, the aspects can be a little bit lower, and then you still could maybe thrombolyze in this situation. The second topic is minor stroke and very severe strokes. As you remember, the meta-analysis shows if you're on the left side of this line, the odds ratio of doing thrombolysis at different degrees of NHSS, you can see even very small NHSS seem to have a benefit, and very severe NHSS also seem to have a benefit. So actually any stroke severity, as you can see here, will have a benefit. So this can actually be said that thrombolysis basically works for all stroke severities, also for minor strokes. At the same time, there is some data that if you have very minor strokes, that is non-disabling stroke, that maybe thrombolysis doesn't really work. So we would then thrombolyze a minor stroke if the NHSS is about 4 or 5 or higher, or even smaller than that, like 2, like for acute hemianopia, because this minor stroke is still disabling. Or also a severe vertigo from a pica stroke, for example, where the patient cannot stand anymore, although the NHSS may only be 1 or 2. You would still thrombolyze those patients. Now, how about in very severe strokes? There is no upper NHS limit to thrombolyze, but just be careful if your imaging shows that more than 2/3 of the ischemic arterial territory is already infarcted, it's probably too late. Or also in the brainstem, if you have a vascular occlusion, if there is extensive transverse core in the brainstem imaging, then it's probably too late. Here is an example of a left ACA stroke. This is an MRI diffusion images. You can see this left ACA stroke pretty much already takes most of the territory of the ACA. So even if I'm early in this patient, it's maybe already too late or no use to thrombolyze this patient, because basically the ACA territory, which is ischemic, is already being lost. If you're not certain whether the patient has a stroke or not, or could it be a stroke mimic, should you thrombolyze or not, you remember all the different stroke mimics and also chameleons, that these are the strokes that you maybe miss, or the strokes that you think it's a stroke, but it's something else. So these are the frequent ones that you know, an epileptic seizure, which imitates a stroke, or a migraine with aura that imitates a stroke. And at the bottom, there are more rarer causes of stroke imitators and chameleons. So what should you do if you're not quite sure whether it is a stroke or not? And of course, it happens all the time. In my hospital, for example, we miss strokes every now and then again. They also over-thrombolyze strokes. You can see here is the rate of too many thrombolyses of people who have an imitator, and we still thrombolyze them. And as you see in the years 2014, 15, 16, we had a lot of imitators or mimics that we thrombolyzed because we just wanted to become quicker and quicker with our thrombolysis, and then made more mistakes. The last few years it went down a little bit again, but we're all at risk of doing that. So how do you act in this situation? Well, there are clinical reasons to suspect mimics and chameleons, and these clinical reasons could be, if it's not a non-classical stroke presentation, it may be not stroke, or if the patient profile is not very vascular, it may not be stroke, or if the circumstances are particular, it may not be stroke. But the same 3 risk factor of having a stroke imitator are actually also risk factors of missing stroke. So for example, if somebody has a non-classical stroke presentation, you may think it is a seizure or a migraine and you missed a stroke, or in a young patient with very few risk factors, you also missed a stroke. So it's really a tricky thing. So for example, if the exact onset of stroke cannot be defined, it may be a stroke mimic. Or again, if the patient is younger, it may be a stroke mimic, but it still may be a stroke, of course. Or in these circumstances, when patients have other neurological or psychiatric diseases, it may be a stroke chameleon. You think it's another disease, but in fact it's a stroke. So as you can see, it's a tricky thing, but in the unusual situation, we have to be careful. And one way, practically spoken, to deal with it is try to get more information from the patient himself, from witnesses, from the medical charts, maybe from labs, if you think it may be an imitator. Review the imaging with the radiologist. Maybe you can find together early ischemic changes and prove that there is a stroke, or see a hyperdense artery. And if possible, of course, try to do an MRI in this situation rather than a CT if it's available. Or if you do a CT, you can also await the arterial and the perfusion imaging results to find maybe an arterial occlusion or a focal hypoperfusion, and then you have more proof of this patient really having a stroke. So these are the practical things. Now, if you still are not sure whether you should thrombolyze or not, you'd rather thrombolyze. It's probably better to over-thrombolyze occasionally an imitator or a mimic, because we know that these imitators, they have very low hemorrhage risk. How about if you have very young patients, so these are children, or very old and handicapped patients? So again, the meta-analysis of a large data set shows that if you have younger or elder patients, and here are younger in terms of less than 80 years and more than 80 years, you see both of these patients have benefit from thrombolysis. Both are on the right side of this line here of the 1.0 line. So you shouldn't say that very old patients don't have a benefit. If anything, they even have more benefit. But this benefit is a relative benefit. It's a benefit as opposed to very old patients who are not treated. So let's be clear, elderly patients, of course, have a not so good outcome because they are elderly. Their absolute likelihood to have a benefit may be less, but the relative benefit is still there. So we have to be clear that elderly patients clearly should be given thrombolysis, just like less elderly patients, because they get at least the same relative benefit. Now, if your younger or elderly patient has pre-existing handicap, or is very frail, or even has a terminal disease, what should you do? Well, there is only one thing to do, really go and try to assess this individual situation. There is no overall rule. You should try to understand the patient's situation, the patient's preferences as well, of course, usually through communication with the family. Now, but there's still a couple of kind of red lines that you probably should not cross. So most international and national recommendations would say not to thrombolyze if your Rankin score before the stroke is 4 or more, especially in a very demented, very immobile patient. If the quality of life was already very poor, that is somebody who already went towards the end of life, or also if life expectancy is less than 3 months, so typically in an advanced oncological disease. How about children and adolescents? Well, as you know, there is no randomized data available. The other problem is that in children, of course, stroke is more difficult to recognize, so they sometimes or often arrive too late at the hospital. But still, what most recommendations say is that thrombolysis may be considered in these patients with the same criteria as in adults, after discussion among adult stroke specialists, pediatricians, and of course the parents and maybe the patient if possible. So it's an individualized decision at the end. What if there are cerebral pathologies in the brain that may be at risk of bleeding? So here is a checklist for patients who had a recent clinical stroke in the last few days or weeks and now have another stroke, or where you find by chance a subacute ischemic stroke on imaging, like this patient. She came with a new aphasia, which was actually due to a new stroke here, which you cannot see. It's only visible on the perfusion imaging, but we found that she already had a subacute stroke here in the same territory, which was actually amazingly silent. So should you thrombolyze this patient or not? Most recommendation would say it's okay to thrombolyze a patient with a recent stroke, symptomatic or asymptomatic recent stroke, as long as this stroke lesion on imaging is relatively small, such as less than 10 millimeters. This one is a little bit bigger. This is about 15 or 20. So this one we would maybe not thrombolyze. If you have moderate to severe chronic leukoariosis, should you thrombolyze? Yes, you should still thrombolyze, but you have to be aware that there's a slightly increased bleeding risk. Now, in patients with previous intracranial bleeds or with microbleeds, asymptomatic microbleeds on MRI imaging, what should you do? Well, if you have a patient with a history of subarachnoid hemorrhage with a completely treated aneurysm, you can thrombolyze him. If there is a history of intracerebral hemorrhage, there is a relative contraindication. That is, if the blood pressure is now well controlled, you may consider doing a thrombolysis many months or years after the previous hemorrhage. Well, in subdural hematomas and hygromas, you can thrombolyze unless the subdural hematoma in the past was really spontaneous, which would indicate the high fragility of the vessels. How about these microbleeds, as you can see here on this image? Well, if there are a few microbleeds, deep or superficial, it's fine to thrombolize. Starting with about 10 microbleeds to start, the risk of bleeding starts to increase. And at some point, you should not thrombolize anymore, but nobody knows the exact cutoff. Now, let's have a look at some further intracranial pathologies. If you have tumors and malignancies, like active intracranial malignant tumors like glioblastoma, of course, you should not thrombolize. But if this malignant tumor or metastasis is in complete remission, a couple of months or years later, yes, you can thrombolize. Benign tumors like this meningioma, you can thrombolize if you are convinced that the current symptoms are due to a stroke and it's not due to this intracranial benign tumor. Systemic malignancy, so active systemic oncological disease, can be thrombolized if there is no active bleeding. But again, we wouldn't do it if life expectancy is less than 3 months, or if there is a current GI cancer, active GI cancer, which have a rather higher risk of bleeding. Finally, intracranial vascular malformation. Here you have an arteriovenous malformation, and here you have a cavernoma. Now, these you should usually not thrombolize if they have a certain size, or if they are multiple, or they has been a previous bleed. So these kind of cavernomas maybe are too large and should not be thrombolized. However, very minor vascular malformations in the brain, like developmental venous anomalies here, or capillary telangiectasis, can be thrombolized. Occasionally, even a single very small cavernoma can also be thrombolized with reasonable safety. If you find a cerebral aneurysm on your imaging, or maybe some patients have it already known before the current stroke, well, it's a little bit a question of the size. So most recommendations say if it's a relatively small aneurysm, like most aneurysms are less than 10 millimeters, like this one here, yes, you do thrombolize. If the size is moderate, between 10 and 25, you should discuss with the neuroradiologists. And if it's a giant aneurysm like this one here, usually we would advise not to thrombolize. So again, most intracranial aneurysms are small, and you can thrombolize them. Unless, of course, you think the patient had a recent subarachnoid hemorrhage, but this is usually known. What about patients who take antithrombotic medication like aspirin, warfarin, and so on, or have hematological disease? Well, here you have aspirin, monotherapy, clopidogrel, even one of the new ones, aspirin plus clopidogrel combined. These are all fine to be thrombolized. So this kind of pretreatment can be thrombolized. Now, if the patient has been on aspirin and ticagrelor, or aspirin and prasugrel, currently we don't have enough data really. We think probably they can be thrombolized, but it's a little bit uncertain. How about patients on warfarin? Well, here it of course depends on the INR. So if your INR is less than 1.7, you can thrombolize, otherwise not. Patients on rivaroxaban or apixaban, we, if possibly, try to dose immediately the anti-10A activity, and we expect them to be below an intermediate range. So up to an intermediate range, you can still thrombolize, but if it's really elevated, then probably you should not. Same thing for anti-2A factor antagonist dabigatran. We can use the thrombin time here, or the hemoclot test, or we can pre-treat with Praxbind, as you know, the antagonist, but this is rarely available. Patients on heparin, hospitalized patients on heparin who have an acute stroke, they also should have a dosage of anti-10A. If you don't have the anti-10A dosage, you can safely thrombolize if the patient has taken his or her last dose of rivaroxaban or apixaban about 48 hours before, maybe even 24 hours, but 48 hours is a quite safe time limit. Somebody with low platelets should not be thrombolized. If they are below 100,000, you can actually still discuss between 50 and 100,000. The bleeding risk is not really very high. So you may consider occasionally, but below 50,000, you certainly should not thrombolyze. Or somebody who has a spontaneous elevation of these lab values due to liver disease or whatever should not be thrombolyzed either. On the other side, we just remind you, if a patient has no history of recent bleed or of taking anticoagulants, we do not wait for the lab results to decide on thrombolysis. So we would not wait for the platelet count in usual patients who do not have a history of recent bleeds. We would thrombolyze them before we know the platelet counts. About some systemic diseases and interventions, again, history of bleeding, especially recent, would be contraindication. Internal bleeding, patient with gastrointestinal, urological bleeding, if it's active, it wouldn't. If it's rather remote, it's okay. And sometimes you check with a specialist, but sometimes it's so remote that you really don't worry about it. Aortic dissections can be thrombolyzed if they're asymptomatic or completely treated. And eye problems usually are thrombolyzed as well. We often say that it's maybe less severe to lose sight on an eye than to lose language or keep a hemiparesis. So usually we rather do thrombolyze. In recent interventions like major surgery or internal organ biopsy, well, if it's a non-compressible site, you should not thrombolyze. But if it's a compressible site and the surgeon who did the intervention or some other surgeon says it's fine for him or her, then you can do it. With lumbar puncture, we now don't think it's a contraindication anymore. Intracranial surgery remains a contraindication for several days or weeks. And after coronary angiography, where the patient has an acute coronary syndrome and the coronary angiography provokes a stroke, it's of course okay to thrombolyze unless the patient is fully anticoagulated. Other cardiac conditions, a suspicion or a known endocarditis, pericarditis should not be thrombolyzed. Pericarditis, yes, if the cardiologist said it's very minor. If you have acute, subacute, or chronic myocardial infarction, basically, yes, you can thrombolyze. The ESO recommendations say they should not be thrombolyzed between 6 hours and 7 days after STEMI because there is a certain risk of cardiac rupture. But this is probably minor risk. If the patient has vasculitis of the brain, he should not be thrombolyzed. And finally, a few other situations during menstruation, menorrhagia, pregnancy, and postpartum. All these patients basically should be thrombolyzed. Well, of course, if you have a pregnancy-related stroke, you should discuss with the patient, if possible, or with the next of kin. There is a risk of the fetus of hemorrhage in the placenta and loss of fetus. This risk is not very high. It's less than 50%. But sometimes you say it's more important to save the mother at this stage than the baby. In the postpartum situation, the risk is, of course, highest in the very first few hours after giving birth, and then the risk will decrease very quickly. In recent trauma, if there is moderate to severe head trauma, you should not thrombolyze for a few weeks. In minor head trauma, yes, you can thrombolyze if there is no subdural hematoma or so. And if there is other trauma elsewhere in the body, with or without fractures, you should discuss with the specialist who knows the patient, and you should decide together. Of course, if the cause of your stroke is in cervical artery dissection, we do thrombolyze. Of course, we do thrombolyze posterior circulation strokes if they're within the time windows. Epileptic seizures and very high and low sugar values should not be a contraindication if you're sure that there is a stroke. So most of the times this means that you have imaging proof of stroke. Very high blood pressure at the time of thrombolysis. Well, if it's feasible that you lower the blood pressure to approximately 185 over 110 or a little lower, yes, you thrombolyze. If it's clearly higher than that, like you cannot get it below 200 or so, you probably should not thrombolyze. So in summary, you have seen there is quite a long list of potential difficult situations, of contraindications, of relative contraindications. In my hospital, we have a pocket card where we have listed all of those, the absolute contraindication, the relative contraindications. But as you understand, in the past, we have had a few indications and a lot of contraindications, but nowadays, many of these contraindications have actually disappeared or have become relative contraindications. So there are relatively few real contraindications like active bleed or active tumor in the brain or a very low platelet count or somebody who has a high INR from taking warfarin. But there are a lot of good reasons to thrombolyze also older patients, younger patients, severe strokes, less severe strokes, patients with hyperglycemia, and so on. So we have become quite more liberal with thrombolysis, but we keep respecting some absolute and relative contraindications. Many thanks for your attention.
Thank you very much for a very nice summary of indications and contraindications. We know that the indications are increasing, contraindications are definitely becoming from absolute going into relative, most of them. But it's always good to have the checklist either in your pocket or in the emergency room somewhere. And at every stage, one should consult if there's a doubt anywhere. But it's still that it should be taken into mind that one should not waste any time in selecting the contraindications or relative contraindications, and go ahead with saving time as much as you can. Is there any questions about this talk? According to my watch, we have about 5 minutes.
Okay, so if I may, can I ask? So this is in fact a little overshoot from yesterday's case presentation. I actually have a real case here. And this question is to Patrick, all of you, is that there's an 89-year-old and a very active 89-year-old and a very high profile person for the country. And he has recurrent posterior circulation ischemia going on for a week. This is almost like crescendo TIAs, like crescendo, posterior circulation thing, imminent posterior circulation stroke, has on investigations a pacemaker implanted for very transient atrial fibrillation, not on anticoagulation. And he also has a very critical mid-basilar stenosis. Almost 90% there. So you have a dual pathology, and he sort of stabilized only on low molecular weight heparin and one antiplatelet. And every time we try to shift him to apixaban because of his frail old situation, we put him on 2.5 VD with an antiplatelet. He has an ischemic event, so he's still on that. So my question, 89-year-old, pretty frail, but otherwise absolutely important for the country. And do I stent him? How long do I continue on this low molecular weight business? And every time I drop his blood pressure to below 150 systolic, he again has a symptom. So with that kind of an anticoagulant and a combo, I'm trying to maintain a higher systolic. And what should I now go on to apixaban 5 milligrams VD, again give him as a combo? Let me know. This is a real life situation. I need help.
I can just add one more case, which I managed. I started seeing the patient 5 years ago. She was 85 years of age, very healthy 85, bilateral carotid occlusions. Started having TIAs, and she was stabilized only on Coumadin, warfarin full dose. I kept her on warfarin, and every visit, every 6 months, I used to tell her, next visit, I may consider withdrawing it because there is no indication of continuing anticoagulation. When she hit 90, I told her that I don't feel comfortable in continuing anticoagulation for you without any indication. I'm going to stop it. It took 3 months for her to get a massive stroke and die. I still feel that whether there was a place to continue it. These are very challenging things which you are telling, and most of us, we tend to give anticoagulation to patients with posterior circulation severe stenosis without having any evidence, just thinking that's the slow flow state. and might be the anticoagulation. It might be helping a bit, but I don't think anybody has a definite answer unless somebody has some different thoughts. Patrick, you want to add something?
Padma, I didn't quite follow. Did you give the patient both aspirin and low dose
Heparin.
apixaban?
Yeah, low dose apixaban. Yes,
and aspirin.
and aspirin.
Okay, and low molecular weight heparin.
So when apixaban didn't seem to, again, he would have these, the homonymous visual issues. He would become ataxic. So we shifted him back here. So would you advise stenting in him? This is a dual pathology.
Anyway,
clearly.
for the antithrombotic, of course, you need anyway an anticoagulation because of the atrial fibrillation. So you put the anticoagulation, as you have mentioned. You can give also normal dose, actually, apixaban, because in the cardiology trials, high dose on regular dose apixaban plus aspirin wasn't particularly dangerous. So I would give aspirin or Plavix, actually, you haven't tried that, with regular dose apixaban. So you have kind of a double treatment, and the apixaban would replace the other antiplatelet which we usually use in these severe atherosclerotic situations, but I only would do it for 2 or 4 weeks. And then I would stop probably the aspirin or the Plavix which you have and just keep the high dose apixaban. Now, you probably tell me that this wouldn't work, which could be possible. The other things you have to do, as you mentioned, is maybe keep the blood pressure a little bit higher, give the patient a little bit time to get used to it. That is, keep to mobilize him as much as you can. And then the last thing, as I told you yesterday, I still do not believe neither in anticoagulation for atherosclerotic stroke. I don't care whether it's in the anterior or posterior circulation. This patient needs anticoagulation for a heart condition, but I don't think for posterior circulation stroke there is any better reason, if the stroke cause is atherosclerosis, to give anticoagulation. And again, as I mentioned yesterday, the data for intracranial disease, anterior and posterior circulation, are really quite scary for stenting and angioplasty. And I mean, that's the risk in this patient. He's a high profile patient. And if you have high profile patient, everybody pushes you to do something, and you will often do more damage than good. So I just would say, no, I'm sorry. In the York situation, I think intracranial stenting is more dangerous than beneficial.
I'll refer him to you, Patrick. He won't mind coming there.
Very good.
Thank you so much. Thank you.
I think we move on.
I just wanted to ask you a very quick question. There's no time, so I won't just a very, very quick question about what's your take on people who are on dual antiplatelets? Even though the guidelines don't suggest an absolute contraindication, I think in real world practice, we need to have some more data because we do see sometimes poor outcomes with bleeds. So I want your take on people on dual antiplatelets.
So the recommendations are quite clear now. We have at least 2 large-scale retrospective studies which say if you're on aspirin and clopidogrel, the risk of bleeding with thrombolysis is only very slightly elevated, but not statistically significant. So somebody on aspirin and clopidogrel, basically, I don't hesitate, and I do thrombolysing them, knowing that there's a slightly increased risk. If there is aspirin and ticagrelor or aspirin and prasugrel, I would be more careful, because we have just very little data at this point. And by being careful, I mean, I would then just look at other factors where the patient could bleed. You remember who bleeds? Well, people with very high sugar bleed, with severe leukoariosis, with very advanced age, and with very large early core. So these patients then probably I would not, if they're on aspirin and ticagrelor, for example.
Thank you very much. We can continue with the next.
So Dr. Call.